Thank you to all our speakers. We'll go into a few cases.
So this is a case of 24-year-old MVC, neuro intact, some midline tenderness. He was placed in a collar. This is a video. I'll let it play through, but so pars fracture on the right, C2. A little bit of distraction at C2-3, disc space, and displaced fracture on the left as well. So isolated C2. Not a great place for the vert either. So in our institution, they get CTA if they have any injury through the transverse frame, and so CTA was obtained. Won't show that. But the MRI scan confirms that there's a bit of a discal ligamentous injury at C2-3, really capacious canal. Neuro intact 24-year-old with this injury. So, John, you want to, is this a collar? Is this a reduction halo? Is this an anterior C2-3 ACDF? Is it posterior C1 to 3? Is it a lot of options? How would you
This is probably like a 2A because it looks like it has flexion but no translation. Fracture's pretty horizontal, so back in the day when we would reduce them with traction, this would be a contraindication to traction probably. So we used to put them in traction, reduce them, and put them in a halo. You know, I'm not adverse to the halo, but everybody else is so adverse that we've used the halo less and less. This would have been a patient we would have put in a halo. I'd put this patient in a collar now that he's healed, the disc ossifies. They all have disc injury, so when we get an MRI and say what has disc injury, only the non-displaced ones don't. So I think this is pretty well aligned. I'm probably putting this in a collar unless they're all multi-trauma, and I think it'll help them mobilize by fixing them. And I'd have to look through the images. If I was going to fix it, this might be amenable to direct osteosynthesis, at least on the one side, maybe not the other, but I'm putting this in a collar and upright films weekly for the first 2 to 3 weeks, and if it stays minimally displaced, it'll heal satisfactorily.
Next, John.
I agree with the analysis. I think the comment about halos is, although they are considered old-fashioned, but the people who do the absolute best in halos are very young, and this is a patient in their 20s, and I think that I would feel more confident that it is being immobilized in a halo than a hard collar, and I think that that really would be the best non-operative management. If it needed operative management, if the anatomy is amenable to it, a C2-3 ACDF would be an excellent way that would avoid touching the C1-2 segment, and which is a much more morbid loss of motion.
Tim?
I think you put this in a collar. My question to John is, do you treat this in a clavicle-based collar like an Aspen, or you do CTO type thing?
I mean, you want extension, so really a CTO is probably better, but frankly, I would just put it in an Aspen collar.
Okay. And it depends on what the upright x-ray looks like. If you see that C2 vertebral body sublux, then you know you're getting more distraction. But again, these do heal predictably, and for any residents or fellows, if you're on your boards, this goes into a halo, okay? The correct answer here is a halo, and then close follow-up.
That's a good point. So it's canal expanding. What's acceptable alignment in the collar? If they're displaced, how much? How do you measure that?
I don't know. That's a good question. I don't know that we know a real number, but, you know, this is angulation, no translation. You know, I'd probably set 10 to 15 degrees of angulation, and translation probably just 2-3 millimeters or so is fine. Even with the translation, some of these ones that are translated but not flexed, oftentimes like the disc space will be narrowed, and those quite often they auto-fuse. So I'd accept, you know, up to 2-3, maybe even as high as 5 millimeters of translation.
Right.
And I measure that at the vertebral body level.
Yeah, I agree with those measurements. I don't use a lot of halos in my practice, despite the fact that I showed one in my talk. But it's a once every few year type of event. But I think the young patient who fails non-operative treatment for this, that has 4 millimeters of translation, or an odontoid, is really an ideal patient for it. If not, I think an ACDF at 2.3 is totally reasonable. But this is going to get a Minerva for me. I guess my question for the panel would be, do you guys ever use Minervas, or do you feel like an Aspen is easier or better? I know the literature on it is pretty weak, but I do use a Minerva for things like this.
Minerva's an Aspen's definitely easier for sure.
Yeah.
The Minerva, you can exert more force on the neck relative to the chest, but boy, they do hate them. And, in young patients, they'll tolerate them like a halo, but the elderly patients get the cubit eye and things. So in the older patients, I almost never use them. In a young patient, because you can mitigate the risk of decubit eye and things, it's a reasonable choice. Probably a better mechanical choice.
Dr. Daly, any thoughts?
Yeah, no, I agree with the concept of a Minerva in this situation, to try to get as much extension and try to get that odontoid angulated posteriorly as opposed to anteriorly. I think that would be a good case for it. And it's going to be relatively well tolerated in a 20-year-old kid.
Yeah, I don't disagree. I mean, first thing I'd do is send these images to Tim and ask him what I should do. But no, I would, though, in this patient, given the kyphosis and posterior distraction, be more worried that this is going to fail non-operatively than I think some of the guys on the other side feel. And I would have a low threshold to do a 2.3 ACDF in this patient, just given the amount of distraction posteriorly, and then you've got that disc, which just looks like it's kyphosed, and that increased width in the back. I know it's a capacious canal, so I'm not worried about a neurological injury, but I just worry that this won't heal.
So this, I didn't share the upright x-rays, but a little bit of focal kyphosis, no translation. So this went on to reduce pretty nicely, and this is in the OR, so it makes you wonder, could you have just reduced and haloed this? That's what you're thinking here. Not a lot of distraction or kyphosis there at the C2-3 disc. But you could palpate the fracture, and there was bony apposition enough for ORIF. And so lag screw technique over-drilled the posterior elements with a large frag 4.5, and then got a lag screw across, and then took it down to C3. So thoughts?
Why take it to C3? Because I think if the anatomy is amenable, your screws are lagging across the fracture site. Why take it to C? If the facets weren't dislocated, why take it to C3?
That's a great point. So the C2-3 capsule should be intact. Most of the discs look pretty good. Maybe screw across both sides bilateral. A 24-year-old bone, that probably would be okay, huh?
John, doesn't that angulation of that disc sort of worry you a little bit, that there's more of an occult sort of disc injury there at 2.3?
There's always an occult injury in Hangman's unless they're non-displaced. So the anterior longitudinal ligament's intact here, and you can use that anterior longitudinal ligament and basically ligament ataxis. When you screw them in the back and you hold it down and you lock in the fracture, it's like a pelvis fracture with an open symphysis. You can just plate the symphysis, and the posterior ligaments close down and will heal okay. So you can use the posterior ligaments. In this case, you can use the anterior ligaments, close it down, and I wouldn't expect it to sublux. This is different than one that may have had a lot of translation to it, where the anterior longitudinal ligament and anterior annulus is also disrupted.
Just a quick question. I've only done this once. It's a pretty rare injury, but I was a little underwhelmed with the purchase. Did you have really good purchase as you did that ORIF, and did that influence your decision to go to 3?
Yeah, good question. So that first picture with a curette or something in the fracture site, I kind of measure out how much bone you'll actually have, and really almost go bicortical with this. And a 24-year-old bone, if you really lag the posterior cortex and you're not purchasing the screw threads on that, but you're actually getting across the fracture, it really sucks it down. And so it's the contralateral side that starts to book open because it's such good fixation in young bone. So pretty happy with the purchase to John's point, probably could have just done a screw across, or actually, upon reduction in the OR, I kind of wished I'd considered them for just a halo. Like, if I got that, I might have would have just said, let's just put a halo on. So.
I mean, the reality is of including C3, the morbidity to the patient, other than a little cost of some screws, is almost nothing. Like, they're not going to miss that one motion segment. So I don't think it's a big issue.
I think we have another case here.
That was a great case. I think the key point there is the morbid approach is to go up to C1, and I think we're a little bit more on that tomorrow.